Mastering Tools, a focus in pharmacologically aided airway management. This is a presentation by me. My name is Eric Stemple, and I just want to give a quick talk in mastering the tools that we have for managing airways. The need for managing a patient's airway really has become one of the most difficult decisions we make as a provider. The patients who are in obvious need of airway management, that decision is easy to make. It's the patients who we're not exactly sure, do we need to take over and manage this patient's airway? Do I need to provide them with some medications that will allow me to do so? And is the risk versus benefit of this really worth it for this particular patient? So we've decided that we're going to manage this patient's airway. Now it's time to decide, do we need to use drugs for this? And this really comes down to assessing the patient and going with a crash airway algorithm versus a drug-assisted intubation or rapid sequence intubation as we traditionally know it as. So as a provider at any level, the ability to assess a patient really is probably the most important skill that we have. And we can teach anybody to perform different procedures, but the ability to identify the appropriate time and place to perform these procedures really is the biggest skill and most important skill that we have. So this really is what separates the Neanderthals from Einstein, the ability to assess the situation, understand what's going on, and provide the proper care. So if we dig into this and really think about, this is the time to apply those critical care skills or that critical thinking. So what is critical thinking? And if you imagine critical thinking like having a box of Legos, and everybody knows what Legos are, on the package there's a picture of whatever toy that you're going to make. But if you think of it as this is the limited amount of parts that we have, these are the tools that we've got, and now we have to use what we know and provide our knowledge and experience to build whatever it is the situation calls for. So sometimes it's taking those tools that we have and using them not exactly as they are instructed to come up with a solution for providing the right care for this particular patient. So we've decided that we have to manage this patient's airway, and we're going to use some medications to aid us in this process. Now the most important part of the entire procedure takes place, and that goes into the prep work. So anybody who's ever painted, you understand that you don't just slap some paint up on the walls and everything looks great. The real skill in this comes in the prep work. So that's taping off everything, sanding things down, patching holes. There really is a lot more work that goes into the preparation, so when the application of the paint goes up, that part looks easy. And if we think about intubation in the same way, if we've done all the steps of preparation prior to, the actual part where we intubate the patient, this should look very easy. And if we've done all the prep right, we're going to come out of this looking like a hero because it's going to look like a work of art. So here's the part where I break everybody's heart, and I hate to tell you this, but you've been lied to for your entire career, and this goes all the way back to the start of your education, and I'm guilty myself of teaching this concept, and it's not 100% accurate. So let's talk about what that is. So first I'm going to ask you a simple question. What is 220 pounds converted into kilograms? All right, and now you're in your mind, you're thinking, oh, that's 100 kilograms, 220 pounds. That's easy math. I've known that my entire career, that if I want to figure out what a patient's weight is in kilos, I divide that by 2.2, and that's an easy way for me to figure out what pounds to kilos are. And in medicine, we're typically using the kilograms to accurately give medications. So we've just had this drilled into our head that 2.2 is the conversion for pounds to kilos. So is that really accurate? Well, the truth of the matter is it's not accurate. It is close, don't get me wrong, but the true conversion comes out closer to 2.205. So 220 pounds in reality is actually 99.77324 kilograms. Okay, so you're probably saying to yourself, well, that's not really that big of a deal. That's getting me close enough. And you're right. That is true. It is getting us close enough, especially for these particular medications that we're going to be using in our drug-assisted intubations. So let's talk about what does that mean for us. Well, as you can see here, and this slide is kind of busy, but there are a range for the therapeutic dosages for each of these medications that we'll be using in the rapid sequence intubation or the drug-assisted intubation. So in orange, what we see to the right, those are the standards set by WVOEMS and HealthNet, and that's what we're using for each of these patients. But the real takeaway for this is understanding that we're falling somewhere in the middle of the range of medication. So it's not a hard and fast rule, but there's a range of this drug that we're trying to get the patient in. And once we get the patient up to that therapeutic range, then we get the desired effects from that. Now, the point I'm really trying to make here is that easy math makes for fewer mistakes. So don't get too wrapped around the axle when it comes to figuring up what the dosages are or what the patient's weight is. We're just trying to get close here. So when we're trying to figure out how much medication to give a patient, we're most likely estimating what the patient's weight is. So in doing this, knowing that there is a range for the medications, then if we're just getting close to what the patient's actual weight is, then we're still falling within that therapeutic range for those medications. So let's think about what would be easier to dose a patient weighing 100 kilos, 90 kilos, 80 kilos, etc., or are we trying to go to 84.2 or 96.3 kilos? If we stick with the easier math and whole numbers, we're still going to be in the range and get that desired effect from these medications. So don't overcomplicate this. Try to stick with easier math. If we're going to go by tens, if we're going to go by fives, but don't overcomplicate this when we're starting to figure out these calculations. Make it easy on yourself and understand that we're still getting the desired dose for this patient. Let's talk about a drug that is kind of on the chopping block when it comes to pharmacologically assisted intubations, and that's lidocaine. So per the state Office of EMS and per our standards guidelines for HealthNet, we're still administering lidocaine if we believe that there is a possibility of increased intracranial pressure for this particular patient. So that could be a trauma. That could be something where maybe they're having a stroke. You believe something has caused the increase of ICP for this patient. And that's when we're going to consider lidocaine. And this is going to be dosed at 1 milligram per kilogram. So nice, easy math. And we're going to go ahead and dose that 3 minutes prior to the actual intubation. Now we're going to roll into one of the most important drugs that we're going to give to this patient. That's fentanyl. So we discussed briefly lidocaine, and the concept for that is that it will dull the vagus response when we're actually doing the intubation. So what is fentanyl doing? Well, fentanyl is going to do a couple things. So it's an analgesic, and intubation is a very painful procedure. So it's going to help dull that pain, but also there is some recent research in the literature that shows that fentanyl may be as or more effective with numbing the vagus response during intubation as lidocaine. Now, once we've provided those procedures, what fentanyl is going to do is aid in sedation. So it kind of numbs up the patient and makes them less responsive to pain, and that's going to mean less required sedation medication for the patient. So there really are a lot of things that fentanyl is doing and is very beneficial. Now, in the algorithm, per the state, fentanyl is not optional prior to intubation. This is number 2 on the list of medications to administer, and we are certainly going to administer that. Now, the range for fentanyl is 1 to 3 mics per kilo, but per the WVOEMS and HealthNet, we're going to go with the 1 mic per kilo dosage on this. Now we find ourselves at a crossroads, and I hope that you've determined what medications you're going to be utilizing prior to this step. After giving lidocaine, after giving fentanyl, I hope that you've already determined which of these routes you're going to take. But let's talk about this crossroads, because now is the point where we're either going to be giving succinylcholine and etomidate or giving ketamine and rocuronium. So here's the conundrum, and we have a lot of tools in our toolbox, and it's really important that we use the right tool for the job. So anybody who's ever been growing up and helping their dad, and I'm sure you've heard that a pair of pliers is not a hammer, and here you can see a crescent wrench is certainly not a hammer. So we have a lot of tools and tools that are specialized in doing a good job, but if you use the wrong tool for the job, then that tool is not going to be as effective. Why are we using succinylcholine? Well, we've always used succinylcholine, and why do we use those? They work really well. They are effective. We've treated so many patients using these medications, and they really do work well. But there might be better tools for the job, and I'm not saying throw out your succinylcholine. There's always going to be room in the toolbox for those older tools, and there will be certain cases where these are still probably the best tools for the job. Now we can see that the side effects for succinylcholine is a pretty extensive list, and this isn't all of them, but we can see that there are a lot of side effects for that drug. And scarier yet, here's an abbreviated contraindications list for Sux. There are so many reasons why we wouldn't want to be pulling Sux out as our first tool for the job, because there's a lot of possibilities where we could actually make things worse for the patient. And knowing the contraindications are pretty complicated to try to remember every single one of these things on the list. Now we're going to talk about ketamine and rock. And this is kind of like the new kid on the block. This is that young doctor who still looks like a kid, and we're just not sure about these. We don't have as much experience, and we're a little bit hesitant to pull these tools out of the toolbox. But why are we so hesitant? I suppose this is a good reason that we're hesitant. There's warnings everywhere for using ketamine, and it does kind of get a bad rap, but it's a really good drug, and we just are faced with so many issues with this. It's really become taboo. We know that there are some side effects that can really be detrimental. So knowing and mastering these tools are really important. And these are just some of the guidelines, and it's written in a way that makes it seem a little bit scary. So is ketamine the big scary monster that we make it out to be? Well, I like to argue no, probably not. Do we need to be careful? Is this the one-stop shop for all your intubation needs? Well, that's probably not accurate either. But ketamine doesn't need to be seen as a big scary monster. It doesn't necessarily need to be such a taboo medication to pull out. There are a lot of good reasons that we want to use these tools. So when is it acceptable to use those things? All right, so hear me out. As you guys probably all can recognize, this is Jimi Hendrix. And Jimi Hendrix is known as one of the best guitarists that's ever lived. Well, let's talk about Jimmy just for a minute. He plays his guitar wrong. And that's strange. Why would you say that? Well, look at him. He's breaking all the rules. He's left-handed. He's playing a right-handed guitar. He's flipped it upside down. He's doing this all wrong. I bet there's not a whole lot of people who would have gone up to Jimmy in his heyday and been like, "Hey, dude, you're playing that guitar wrong." He was a master of this tool. Now, did he use it? Did he follow all of the rules in the book? No, but did he make something work out of bending the rules? I would argue yes. And if we take this approach, we can see that we're able to use these tools. So don't be afraid to look past the, oh no, don't use it this way kind of feel that we have with certain medications. In the guideline for using ketamine, it says that we are fully able and capable of using that medication if the other means or medications are contraindicated. Well, the list of contraindications that we saw just a few moments ago are pretty extensive. So I challenge you to look past what we know and what we're comfortable with, and let's bend these rules. That's the idea of the critical thinking. What do we have in our toolbox? Which Lego parts do we have? What is it that we've got in our hand that we can use it to get the effect that we want, to get the desired need? And we have to look past just what's written on paper and really understand that we have a lot of tools, but to really be effective with these tools, we have to know the ins and the outs. And we also have to be comfortable enough in our skills and ability to push those rules a little bit. And if we're providing care, if we're doing what's right for the patient, then that's all that we're ever asked of us is to provide good quality care. And yes, there might be times when you have to answer for the things that you did, but if you're able to knowledgeably justify the actions that you took, then you'll always be on the right side. So don't let these drugs be such a taboo thing, but really challenge yourself to master the drugs, the medications, and the tools that we have, because that's what's going to make us a standout. So, what does it mean to be a master at our craft? Well, I think anybody can appreciate that it takes a lot more than just owning a paintbrush and throwing some paint on a canvas to make a masterpiece. And we have all these tools at our hand, and if we don't know how to properly use them, then we'll never be able to create a masterpiece. So I challenge you all to go out and become a master of your craft. Really become a master at knowing how to use these tools, these medications, know the ins and the outs, the indications, the contraindications. And once you can really dig in and know what these tools can do, then all of your intubations can really become happy little intubations.